So, Dr. Jurevich here, and I just want to share a story before we get started while we're waiting for everybody to sign on today to the meeting. So, I was in my geriatric clinic yesterday, and I walked in to see one of the patients that was scheduled, and I hadn't really looked at what the reason for the visit was. But then, as I walked in, I noticed that there was a burn mark on this poor lady's forehead, and I said, "Oh my gosh, it looks like you burned yourself with your hair curler." And she says, "Oh, how did you know that?" And that's exactly why I came in today. And she says, "How do you know it was a hair curler?" And I said, "Well, I grew up with 3 sisters and I had 3 daughters, so we had a lot of hair curler burns. So tell me how this happened." So anyways, we had a really good conversation. So that was being able to have a little bit of experience in the hair curler route. So today we're going to have a session on the power of observation as part of our presentations that are the combination from the Institute for Healthcare Improvement, and then our own generated, learn one, learn all concept. And we're following up with the Falls Improvement Project. And we'll have a little bit of information about falls that I'll share with you that should help shape our perspective, at least from a geriatrician's point of view, as to how falls should be looked at in the nursing home setting. So, and we're joined today by our nurse, what we call our nursing home peer mentors, as well as our mentors from the IHI and also from the state, for our quality innovations organization. So we have a whole slew of people. And I mention this because sometimes people are new to the sessions, so they're coming midstream or whatever. So we want to make sure we give you enough background to basically get an appreciation for what we're doing and what the purpose of this program is. And just to reiterate, we're attempting to standardize the standardization. We're trying to get everybody involved in nursing home quality improvement to basically do very similar work and to try to lighten the load for doing quality improvement. So we're doing this kind of in aggregate so that people can use, for instance, the root cause analyses and then just modify them a little bit for their facility. They can use some of the interventions at their facility to test and see if they work, so that in all these cases, you don't have to reinvent the wheel. And what we're trying to do is do consecutive waves of quality improvement around safety, patient-centered care, and then quality care. So those 3 QAPI initiatives. So right now we're focused on the topic of safety, which is falls prevention. And that involves both falls prevention as well as fall interventions, with a reminder that nursing home residents average 2.6 falls per year. And as one geriatric colleague of mine said, it's not a matter of preventing the falls as much as it is preventing injury from the falls. And so it's a little different perspective, is how do you create a safe environment? And obviously trying to decrease the falls is a goal, but again, looking at the safety component of that is probably the bottom line for us. So why don't we move on today and go through the IHI curriculum. You can see what our agenda is for today. And then if you don't mind, can you put in whether you did walk rounds last week? And if the answer is yes, what major lesson or point did you discover from those walk rounds? So I really love having people share what information they get. And it could be anywhere from, finding out. I think last week we talked about there was a lot of feedback about staff being stressed. So just give folks a few minutes to type in here. Did you want to say something, Kelly?
I was saying that's very appropriate for our curriculum today about staff being stressed.
Yeah. Yeah. And then, in fact, the one of my colleagues from University of Maryland was talking about pharmacists who have been under stress with the pandemic, and so she did a talk on resiliency. And the other thing that was really quite interesting is that the Red Cross offers a resiliency course for trauma victims, and I just heard that discussed here recently on the news. So I tend to get all my new medical advances from the news now. You don't have to look at the medical journals; it just shows up on the news. But Red Cross has a resiliency class that they offer to post-traumatic stress disorder. Oh, Judy's talking about made a big change for vaccinated employees to change from N95 to surgical masks. So that's more comfortable. I was sharing with my college classmates at a reunion, a college reunion, about how embarrassing it is that somebody with my age having worn a mask and developing facial acne. It's like, good gravy, visited that how many years ago. Great. Wow, multicolored surgical masks. That's pretty cool. I just wanted, I don't know if you guys remember, but with those surgical masks, if you want to make them more effective in face of this Delta variant, you've got those plastic or rubber, overlays that help make it for a little bit tighter fit or more, form fitting. So, and they're equivalent to N95s if you get that flexible piece to apply to the surgical mask.
Cindy, I see your comment on there about being super short-staffed and that possibly being the cause of falls. That it's definitely something to look at, and how can you distribute some of the duties that maybe your CNA is responsible for to some non-clinical staff, like passing trays and doing things like that, so the CNAs can focus more on the duties. I'm sure you guys have something in place, but just trying to think outside the box.
Yeah, I agree. Although quite honestly, from my perspective, while it might be good to have more staff, in fall prevention, a lot of the falls occur unwitnessed. And, so there's and so the question is, how much staff can you really apply, even if they witness the fall still occurred, so a lot of this is, well, as we'll discuss as we move along here about some of the types of things that you could do. I mean, things like scheduled toileting and so forth. If that's being reduced because of lower staff, then that actually is a salient point.
Yeah, that's what I feel like a lot of whenever you have that short staff is the toileting issue. I need to go and I need to go now.
Right. Yeah. So yeah, thanks for pointing out here, doing a lot of education on the fall huddle. That's great. So as you guys are putting these into the chat box, just think about whether you want to make a commentary about that as we move along in the presentation today. And I'd love to hear your feedback on that. Okay, good. So why don't we move on to the next slide here. And so again, in the chat box, have you seen in your changes in your fall rate, pre and post COVID? So a lot of facilities are reporting that there's been an increase in falls. So as alluded to earlier by Cindy. So just want to share, I don't know if you have the information as to what the fall rates are or have been, but some people are comparing the 2020 fall rate to the 2021 fall rate, the aggregate fall rate.
Yeah, and when you talk about fall huddles, and I think something that everyone needs to keep in mind is that when you do those huddles, it's not necessarily just for clinical staff, because if it's as simple as Miss Jones is going to get up for her bedside table, if it's pushed away from her bed and the housekeeper is in her room, the housekeeper can move it closer to her bed. So it doesn't have to be clinical staff that do all of the interventions for falls, and that's why it's important to include all staff that available in those huddles.
Yeah, so Cindy's making that point that I was making earlier, which is that there are, more injury that people are noticing. So I'm going to show you a slide actually that it has been reported that the fall-related mortality rate compared to pre-COVID versus COVID is pretty dramatic.
Cindy, do you have a decreased participation in like your restorative program or just like Part B therapy as a effect of not getting in those groups and such with COVID? And that may be some of that deconditioning.
Yeah, I certainly wonder about that.
Yeah.
I mean, so there's also some evidence about for those that did have COVID and survived, that their recovery period is creates further deconditioning. I mean, obviously the isolation part of that and lack of mobility in general, but also for those that, like I say, recovered from COVID, there's that whole question of their postural stability. Okay, great. Thank you for those comments. And so a discussion to be continued here. Can we have the next slide, please? Yeah, so this is another question that we had. So I think in general, we can understand when staff are stressed, but one of the questions are, what are some of the signs that you're identifying? Is there increase in altercations, verbal altercations? Are people taking more time off? No-show rates and so forth. So just want to kind of get your impressions about how you're making the survey of the lay of the land, so to speak, about staff being stressed.
Yeah, absolutely. And as Dr. Durovich mentioned, it's one learn, all learn. This is an opportunity. If Cindy sees something and she knows that it's indicative of stress for one of her staff, and somebody else may not have realized that is a stress trigger or a result of stress. And so it may be something that you can start looking for. That's why we ask these questions, so everybody can learn from one another.
Yeah, exactly. Yeah, so I can share with you, when I get stressed, I go quiet. So if I suddenly go quiet, that might be something stressing me out, as opposed to reflecting here. So go ahead and just put in the chat whatever your impressions are. Yeah, so Cindy's talking about, folks voice it, more verbal altercations. No shows, asking for time off, staff crying. That's really interesting. Kind of reminds me of an interview I had with a news reporter. So the guy calls me up. He says, "As men get older, do they cry more?" And I go like, "I don't know." It's like, I said, I don't think so, unless they have depression, or whether they're stressed. And I said, so if they get older and get stressed, maybe they would cry more. And then one of my colleagues said, "Oh yeah, older men cry all the time." So kind of a whole different thing, but yeah. So I think that's important that they're having physical manifestations. I quite honestly, I've seen staff who I watch their hands, if they become tremulous or there's hand wringing. So there's a lot of body language that's going on right now, that fidgetiness, people keep messing with their masks. That sometimes indicates to me that there's some level of stress.
Yeah, you could always start handing out those stress balls. Everybody could keep them in their scrub pocket or fidget toys, something to take their mind off of it in the moment. Maybe helpful. I don't know.
Yeah, and Angie's making a really good point here about headaches and muscle strain. And so, yeah, I mean, I've seen that in the clinic staff, and it's real interesting. So I don't know how long ago somebody had indicated that they had a massage therapist come to the facility, and was just working on upper back muscle tension. And then somebody else was talking about implementing a 10-minute yoga, session for people for relaxation. So yeah, we might want to talk about that physical manifestations of stress and how to approach that. And obviously, those are a couple of ideas right off the bat there. I don't know if anybody else has some additional ideas for that. Somebody had also gotten the facility psychologist to come and give like a group, I don't want to call it a group session, but a group presentation about resiliency and how to, better adapt to stress. Good. Okay, so let's move on to the next slide here. I think we have our presentation from the Institute for Healthcare Improvement.
Welcome to Module 2 in this series on leadership roles and behaviors to support teams through COVID-19 as it pertains to psychological safety and well-being. And today's topic will be on the power of observation and how we work to identify team members that are in distress and in need of intervention. My name is Sarah Sjostrom. I serve as the Associate Chief Nursing Officer at Hebrew Rehabilitation Center, and I'll be reviewing today's content with you. In order to support the emotional well-beings of teams and to support skills that build resilience over time, leaders first need to develop the skill of being able to identify where there are problems and where there are teammates that are in distress and in need of intervention. And a great tool for being able to do this is the Stress Continuum Model. This serves as a vital component of the Stress First Aid Program, which is an evidence-based peer-to-peer psychological support system. And it was originally crafted for the military and then later adapted for first responders, and now is being brought into healthcare organizations as well. So you can see that this is a fantastic visual tool that tracks the trajectory of an individual exposed to stress. You can see that on the left, this individual starts in the ready, in the green, ready to go, ready for action, functioning at optimal capacity. As an individual is exposed to stress, maybe multiple stressors, extreme stress, or stress over a prolonged period of time, they slowly move along the continuum to where they are reacting to stress, stress injured, and even if that stress is so extreme or so prolonged, can progress into being ill from stress, which means diagnosable mental health illness, potentially PTSD, diagnosable depression, anxiety, increases in substance use. And these are all particular concerns right now, as we discussed in the orientation, that we are seeing an almost parallel pandemic of healthcare workers who are progressing through this continuum into the red. So our job as leaders is to begin to develop skills so that we can identify when our teammates are moving along the continuum, stress reacting and stress injured, and intervene so that we can stop that progression. So looking at the features listed in each of these columns helps us to begin to identify when teammates are not at their best. You see in the reacting column that someone who is reacting to stress may be feeling more irritable, may be feeling more anxious. Someone who's stress injured may be having moments of panic and rage. These are the moments that we want to capture, recognize, and know that we need to take action. So what does intervention look like when someone is in distress and in need of support? The research that provided the foundation for the Stress First Aid Program identified 5 key components that are essential for responding and intervening in times of trauma or stress. And so as leaders, we can begin to craft responses and interventions based on these 5 factors. An individual to overcome adversity and times of stress needs 5 things: to promote a sense of control or safety, to promote a sense of competence or self-efficacy, to promote calm, to promote connection, and to promote confidence and hope. And there are a number of ways that leaders can do this. For example, throughout the COVID-19 pandemic, things felt very out of control. PPE procedures were changing, all procedures were changing. A key thing that leaders can do is provide clear, transparent communication. This is often essential in a team member's ability to feel in control and to feel safe, that they understand what is happening, that they understand what is expected of them. So for example, something as simple as a leader taking a new policy or a change to policy, being present, sitting down with a team member, and going through that policy start to finish to ensure that they understand. And that can serve 2 functions here. It can make that team member feel more in control and more safe, that they are aware of the process. And it can also help to build their competence and self-efficacy by making them feel more capable of filling the role that is expected of them. It can also help to support connection between the leader and the team member. So as you see, interventions don't necessarily fall only into one bucket. But it's important to be able to distinguish when team members are having a tough time with one of these particular categories. Maybe they're not feeling calm and they're feeling anxious. Maybe they're feeling out of control or not competent. And by assessing these 5 buckets and beginning to build a toolkit of interventions you can take that address these 5 areas, as a leader, you can begin to develop skills to provide support to team members that are in distress. So this can be a simple 3-tiered approach to both observation and action. So to break down stress first aid in the most simplest of terms, you need to first notice when you or when your team member is bumped out of their green zone and progressing through the stress continuum. 2, you need to act by simply acknowledging that there is a concern and stepping forward to provide support to the teammate. See something, say something. And the 3rd is simply be prepared. What are the tools in your toolkit so that you can help to intervene? What are the resources at your disposal? And it does not require an advanced degree in psychiatry or psychology to do this. This is all based on peer-to-peer support that is simple, effective, and intentional. So this is an example to demonstrate the simplicity. Anne is a coworker. She's usually very social, but has become less and less talkative and more isolated. You've noticed something. Now you're going to act. And the action is as simple as this: stepping forward to Anne and saying, "You haven't seemed yourself lately. Are you okay? I just wanted to check because I care about you." This is very, very simple and seems almost ridiculously simple, but is incredibly intentional. In the response, you say to Anne, I'm not just saying, "How are you doing?" because that can elicit multiple responses of sure, fine, etc. It is specifically saying, I'm asking you how you are because you haven't seemed yourself lately. I'm feeling like there is a problem. But you're also, as a leader, being very specific in your first intro to say, I'm checking because I care. You're immediately eliminating anything that would label this as a punitive approach. You're saying to Anne, I care about you and I'm worried, and that's why I'm asking. And then be prepared for your reply. Anne, you've been able to make a connection with her, and now she feels comfortable in saying, it just feels like a lot. Again, responses can be very simple and effective, yet very intentional. So you can say, would you like to take a walk or get something to drink? Sometimes stepping away makes a difference. Or, I was feeling the same way last week and I talked to someone and I feel so much better. I can be that listening ear for you. And again, these are very simple, but they serve very specific purposes. The first response is intentional in that you are asking someone to take a break and take a pause, to remove themselves from a stressful environment, to be able to promote calm as one of the interventions. The second response is a way of intentionally normalizing reactions. Again, letting someone know it's okay not to be okay. I too have felt badly, but talking about it helped me to feel better, and I can do that for you. These are simple and effective and intentional ways to provide support to team members. Thank you so much for joining us in Module 2. Remember, intervention does not need to be complex. It can be simple and yet still effective. We look forward to joining you in Module 3. Thank you.
Great. So that was short and sweet, and I think the take-home message certainly is, the going from the green zone to the yellow zone. Does anybody have any comments about that in terms of any interactions? Have you used this methodology of identifying somebody and then pulling them aside? And did it work or otherwise?
I would also say that last slide we saw in that video where it gives that example of the situation, how you just pull them away and just have that quick conversation, maybe a good resource for you guys to share with like your leadership team, that it can be as simple as this to try to de-escalate someone if they are in that distress situation. I know that it takes a village to run a nursing facility. And I think you have to lean on your leadership team to all be observant of what's going on the floor and then be able to respond appropriately. And, going back to the quality improvement hat here, really try that one unit and watch whoever your unit manager or whatever is on that unit to try some of these basic responses when someone is stressed, or a room where they can go have a drink, whatever, and see if that's helpful to that unit, and then move on from there.
Yeah, thanks for the comment, Cindy, that your director of nursing uses this technique all the time, and it is effective. I don't know if anybody else has this feeling, but I always think that there's a bell-shaped curve of different respondents, right? There are people, there's a Jewish or a Yiddish term called kvetching. There are people on the side that are always complaining, and so sometimes when I always fear that if I lend an ear to, somebody that's what we call a kvetcher or a constant complainer, that you're constantly being taken up time with that person, when the person on the other side of the bell curve is perhaps a little less expressive and perhaps needs a little bit more help. And so it's always trying to, from a leadership point of view, of doing that balance between somebody who just loves to talk your ear off about all the problems they're having. I mean, we see this in the clinic. I can't tell you, the encounter with the hair curler burn, that turned into a 40-minute visit, which, how do you need 40 minutes to deal with a hair curler burn? But a lot more going on, right? And we covered a lot of territory for other clinical problems, half of which, we're dealing with some other COVID-related aftermaths. So you never know, what you unearth. But again, I think we need to also be considerate of balance of time and not be sucked in or pulled in by people that might have excessive needs. And so that always becomes a balancing issue. I don't know if anybody has any comments about that, but I just wanted to raise that as an issue.
Yeah, Dr. Juravich, I think that's a great point. And, you can look at staff as the same as residents and trying to create a basic care plan of their needs, because one staff member may need one thing and another needs something else. And you could do that at orientation. Tell me something that brings you joy and tell me something that stresses you out, and use those little bits and pieces in order to continue to promote their psychological well-being throughout the course of their employment there.
Yeah. Yeah, and I think Sabrina is making a really good point, that the leadership knows who's on that bell curve, and they've adapted, their approaches accordingly. So, yeah, I don't know if there's a real structured approach. This is always a thing of, how do you replicate what you're doing, Sabrina, at another facility? You know, is it, you know, do you do a you know, human resources review, you know, of that bell-shaped curve, and you know, do you look for strategies? I mean, you know, we talked about the buddy system. You know, does the buddy system work? Maybe they need a new buddy, you know, to kind of redirect that energy and so forth. So yeah, I mean, we're in, believe it or not, into behavioral modification in a lot of ways, and this whole system of identifying that is part of the behavioral modification. So we're trying to take those people who are stressed to behaviorally modify them back to the green zone, and you know, what is the best approach for pulling them back into the green zone. And one of the things, I don't know, you know, if you guys have any thoughts about this also, is this whole question of what we talked about, mission. You know, so it's sort of like, you know, why are people there? And you know, what brings them joy in work? You know, and revisiting that, I think that's also a big question at large, you know, for countermanding or countering the work stress that does go on. Okay. Well, thank you for those comments. And I don't know if Jean or Michelle, or do you have any other thoughts about or reflections on this whole question of stress identification and management?
I don't really have anything to add to it, except that staff who are in a situation, who are experiencing stress, I know sincerely appreciate it when it's acknowledged by their leaders. And, you know, it certainly makes you feel appreciated.
Yeah, I think that's good. Yeah, and thank you for the comments here. Just trying to read some of the note here. Yeah, feel confident about the DON identifying stress. Yeah, and getting to know people. So that's again, that's all part of, you know, and the thing that's interesting is that as you get new staff, you know, it may take some time to find these different behavioral patterns. But again, looking for what I call body language. You know, you look for grimacing. You know, do they always look like they're concerned about something? You know, it was kind of interesting. I was watching the Olympic trials, and one of the runners who won the hurdles had a very stressed look on her face. But once she got running, that whole facial expression turned into just, you know, total relaxation. So you could tell there was stress before the race, but went into the moment, you know, the facial, you know, expression went to a more natural thing. So again, just keeping an eye out for, like I say, facial fidgetiness and so forth. Okay, let's move into our didactic portion here about older adults and falls. So we can have our next slide. Okay, so if we got some sharing going on here. Is that Kelly? Are you leading that, or Jean?
I'll go ahead and take it. So
Okay,
today we have, thank you. Today we have joining us from Heart of America Care Center in Rugby, Becky and Brittany. They are the Director of Nursing and the Assistant Director of Nursing, respectively. And I know we spent a lot of time these last few weeks talking about the components of a good fall reduction program. And these ladies have actually put into action a falls reduction program in their facility. And they're going to share the ups and downs of their program with you. So I'll just go ahead and let Becky and Brittany take it from here.
Hi, everybody. This is Becky, and I'm just going to give you a little bit of an overview of what we've done. And then if we want to nail down more specifics, I'm going to turn it over to Brittany because she's actually kind of been the champion for this. But we started our Falls PIP several months ago. I think February was when we first really started it, because we kept seeing an increase in falls, and our falls were, you know, way crazy. Most months above 16, maybe even as high as 22 at times. We're having a lot of falls. And so one of the first things we did was started to really track and put into an Excel sheet what was happening with those falls, so we could start to look for some trends, and that's really helped us a lot. I'll let Brittany speak to that in a minute, but that's really helped us a lot be able to know what to communicate with staff about what's happening and when it's happening, and kind of start to identify why it's happening. So that flow sheet has been really instrumental. And then coming up with a way to make sure that all staff are educated and communicated on kind of what the trends are in our facility and when, kind of what's happening with our residents and getting them educated. Brittany came up with a falls board, which we can show you, so that all the staff know when falls occur, why they occurred, what was happening around the time of it. And that is helping us see some big improvements. So we went from like 16 to last month. Our goal was to have 8 falls, 10 falls or less, and we had 6. And so that was a huge compared to where we have been. And we've also been rewarding staff. So when we meet our goals, we're doing, pizza parties, ice cream sundaes, things like that. So, but I'll let Brittany speak a little bit to and I think we have a copy of if you could put up a copy first of the flow sheet, that shows some of the trends, but the actual Excel sheet where we track everything on.
So every month I just track everything for the resident, the fall, why it happened, the times, and then that separates it into those other pictures that she's displayed. And then I post those to the floors. So then they are more educated on the time of the fall, where the fall happened, things like that.
So if you can go back to one of the other sheets that you put up initially. There.
Yeah, so I post the next 3 slides are what I post on that whiteboard. So the staff knows, okay, this past month, most of the falls were in the rooms. Most of the falls were beside the beds instead of transferring walking. And another one is like, okay, most falls happened on Tuesdays. And then most of the falls happened between like 1 a.m. and 4 a.m. or 3 p.m. Just getting them educated and knowing so then they can be more vigilant during those times. And when they do rounds to make sure everyone's safe during those times too.
So, Becky and Brittany, when a fall occurs, do you do a post-fall huddle right away?
No, we have not implemented that yet.
What is your strategy then for determining the cause of the fall and moving forward with interventions?
We have, it's called a fall scene investigation. And so I guess it would be kind of in place of the fall huddle. The nurse that's in charge and the CNA that was taking care of that resident fill out a written form about the fall scene investigation. And so it answers all those questions about, your typical things. Why did the resident fall? What were they trying to do? Where was it? How were they, found? What was the condition of the room? Did you see any hazards? Were the fall interventions in place? So the fall scene investigation is kind of our version of the huddle.
Right. And that fall scene investigation then is used to populate one of the pages of this Excel spreadsheet. Am I correct?
Yeah, we use all that information, both from the fall scene investigation and from the incident report.
Mm-hmm. Mm-hmm. For those of you who don't use it, I'll just back up a little bit and say that this falls tracker that they're using was developed by Quality Health Associates several years ago. In fact, I noticed on the information that Brittany sent me yesterday that it still has our old logo, the North Dakota Healthcare Review logo on it. So it's been around for a long time. But it tracks, a lot of the very crucial information from each of the falls that occurs that is then used to populate these graphs, such as the time when the fall occurred, the day of the week when it occurred, so on and so forth. And like Becky and Brittany have said, this information is excellent information to communicate with staff so that they're aware of what's happening in their facility and when they have to be a little bit more vigilant. So I have another question for you, and that is that when you were working on your falls reduction program, how did you determine what interventions to implement?
You mean interventions for each of the residents, or what we
know,
wanted to do as a team?
Both.
I think a lot of our interventions were situational. So, looking at that fall scene investigation, and then talking with the staff, just trying to individualize those interventions, for each resident, because those are all individualized. And then as a team, looking at the data as a whole and realizing when most of the falls occur, like which day of the week, why is it that day of the week, or which hours, what can we do to change something to see if, between 1 and 4 a.m., what do we have to do? Make sure our CNAs are up walking the halls and, and not sitting at the desk, that kind of thing, to see if we can reduce the falls during that time. And getting the CNAs to buy into that too, because when they can see that this is, the majority of when the falls happen, then they're more motivated to get out of those chairs and be doing the rounding like we were expecting them to do.
So tell us more about the staff reward program that you have in place.
Basically, we set the goal, and if they meet the goal, then they know ahead of time this is what the reward's going to be. So the first goal that we hit, and we set the goals, at first it was at 10, and then we set it down to 8. But so obviously our idea is to keep getting less and less falls. But when we meet the goal, then when we have our regular IDMs, we reward them. So the first one was the pizza party. The second one was banana splits and ice cream sundaes. So that just, hopefully helps them know that we're thanking them. We realize that they're working hard and that we want to reward that hard work.
Right, and it can be very motivating. I know yesterday when we talked, you mentioned that of late you've had a few falls, but that you were able to attribute those falls to the medical condition, complex medical condition of these two residents. And I think that really highlights, the need for doing a falls scene investigation or a falls huddle right after the falls occur, so that you can implement very specific individualized interventions as soon as possible.
Yeah, and sometimes that even doesn't work. Like June actually turned out to be a really crummy month for us, which was really hard for us to talk about this today, because we had since February, we've been getting better. June has been horrible for us. And that last week of June, mainly, we had 2 residents in our dementia unit that are having some big medical issues. And it's like, despite what we're putting into place, they keep on falling. And sometimes it feels like the only intervention is having somebody one-on-one them 24/7. And we all know we don't have staff for that. So we're doing everything we can, keep bringing them in the commons area where they're constantly watched, things like that, but they still end up falling. So this, we all know we have those times, and we do everything we can. But I liked, what Dr. Jurevich said at the beginning, that sometimes really we have to just try to prevent them from getting hurt, because that's ultimately the worst thing, is if they break a bone or if they get injured. We have to try to make it so that if it's going to happen, it's done safely. They roll out of a low bed onto a very soft mat, they're not going to get injured. But trying to do what we can to prevent injury is also really important.
Yes,
Hey,
absolutely.
Becky, I have a quick question. You said that these repeat fallers on the dementia unit, have you been able to talk directly with the families if they were at home before? Were there certain past times that were more fund for them or anything like that?
Yeah, we're in pretty good touch with all the families, and these two frequent fallers that we're talking about have lived here for, a year and haven't had falls. It really truly is because of some significant medical conditions that are happening right now. So even knowing things that they did in the past, it does help, but it's definitely not the only solution to keeping them safe right now.
By the way, I love your board here. I think that is a great way to share the information with the staff. This is awesome.
It does create a little bit of a healthy competition too. When we have 12-hour shifts and you have days versus nights, then people kind of like not to want to be the ones have the most falls. So they do see when the falls occur, and they do really try to make sure on their shift they're not having those things happen. And knowing, every fall, like Brittany has listed up there, was it a self-transfer? Were they walking? Were they in bed? Was it when they were trying to toilet, that kind of thing. So you can see right away where we're seeing a lot of falls come from.
So you mentioned that y'all have the form that you fill out kind of post-fall. But is this board displayed somewhere that it would be seen by residents or family members, or is it kind of behind closed doors?
It is right outside of our report room, so residents can see it too.
Yeah.
Since we're more of on a lockdown for visits, family members don't really have much access to it, but the residents do have.
Because if you had a fall, say the day before, you could put a little bit of information on here, so that way those other team members that aren't necessarily clinical, that didn't participate in completing that form, they would be able to see, oh, Miss Jones had a fall yesterday when I'm walking by or doing my rounds. I need to watch out for that, or I need to look at the intervention. Since not everybody can necessarily come to a quote unquote huddle, at least they would be aware of what was going on.
Yeah, the CNAs that gets talked about in report. So every time there's a shift change, the people who have fallen in the past week, they review who's had the latest falls. So I think our team is good, but the patient information itself is not on the board. It's all just the most recent one. So those initials, like you see ST, that's not the name of a resident. That means that it was a self-transfer.
So just some reflection. This is really incredible. I love the visual graphics, and I don't know, the pineapple head there is pretty with the sunglasses here as we're heading into 4th of July. It's kind of it's good imagery. And the upside down stick men is good imagery. So there's different ways to approach the imagery even. So at some point, people keep looking at it and they get kind of I don't know, accustomed to the board and they don't pay attention so much. So sometimes you can change the graphics that you're presenting to get more engagement. But yeah, this board, looking at a glance, is absolutely, as they say in England, it's brilliant. So good job. This is really quite nice. I want to step back a little bit and just comment that we know that falls are multifactorial. And so a lot of times, when we start doing this data analysis and we go, here's the time, and then here's the location, it's all good stuff. But then sometimes you need to do a little bit deeper dive so that, for example, 50% of your falls are at night and half are during the day, at least from the data that you showed us for that 1 month. And, so the question becomes, is the deeper dive mean in terms of your root cause analysis, how many of those nighttime fallers or night crawlers were given sleepers, or were on medications that were sedating or hypnotic. So that would be a question. And then you also look at the intention of the individual, like were they transferring self-transferring, or they're going from bed to bathroom. And so you say, oh, they were just, getting up to go to the bathroom. So they need to pull the alarm, and, versus was this person on a scheduled toileting? So we know a lot of people, for example, with diastolic heart failure, they re-equilibrate their water system, right? Their intravascular water. And so dime to a dollar, within 1 to 2 hours of lying flat, they're going to have to go to the bathroom. So some of these are predictable. If you know when somebody is going to need to use the bathroom, if they have, for instance, heart failure, particularly if they're on a diuretic, you'll know automatically that they spend an hour in bed. They're probably going to need to be toileted within that 1 hour, so they don't accumulate it in the middle of the night. So those are different examples of, as you said, multiple chronic conditions is a risk factor. But what is it about those multiple chronic conditions that creates the risk factor, such as re-equilibration of the water and the nocturia, and solving the nocturia problem is one of the goals. So does that kind of make sense?
Yeah, absolutely.
So so I mean, just like I say, doing a deeper dive into this, and so one of the interventions might be with all those night crawlers. You might want to ask what percent were on, let's say 30% of them were on Lunesta or some sedative. Maybe checking with the medical director to stop those and see if you could have an impact on the falls. Maybe substituting them with melatonin, and reassuring the patients and the family that melatonin takes about 2 weeks to kick in. So, don't be surprised if there are some issues. And again, maybe that intervention might cause some insomnia, and then maybe cause more falls. So you have to be careful, as to how that all works out. But it's definitely that would be one approach to think about. So very good. Does anybody else have any other comments? Jean or Kelly? Vanessa, I don't know. I haven't heard from you either.
I
Yeah,
think,
I'll just reiterate, this is beautiful. I love it.
yeah, very good job, ladies. Thank you for sharing with us. And I'd just like to point out that Becky was recently appointed the Long-Term Caregiver of the Year Award. And so we want to congratulate her on that. And we feel the prestige of having you as part of today.
That's awesome.
Thank you, really.
Yeah. Next week we'll have a pizza party in celebration. How's that?
Sounds good. Thank you, everybody.
Thank you.
That's great. Okay, so I'm not going to take up a lot of time with this didactic part of the falls. I'll just spend a couple of slides worth here, and then the remainder of the slides we'll cover next week here. So go ahead and next slide, please. So what we want to do is understand the fall risk factors, and we want to talk about this individual treatment, post-fall assessment and management, and then the more global fall prevention program. So I think Becky had mentioned this in their case, that they address both the individual and the more global intervention program. Next slide, please. So we know that the intrinsic factors for falls, as mentioned just here a short moment ago, was the recognition that multiple chronic conditions lead to falls. As the point I stressed was that medications such as sleepers, hypnotics, SSRIs, so looking at whether trazodone and mirtazapine have a higher fall rate than Zoloft or other SSRIs. And then we know that weakness and what we call sarcopenia, or loss of lean body mass, as well as frailty, is pretty much a condition that people experience in the long-term care setting, especially the long-term care, the long stay residents. Okay, next slide. So we also know that there's postural control problems, and so I put a little replication of this Escher drawing, that shows people going up and people going down, upside down, and every which way. So we want to always consider the environmental hazards. So that should be in your root cause analysis, checking for environmental issues. Also, did it occur with change of position? So people that were transferring from the wheelchair, as to did they go from the right side to the left side or from the left side to the right side? And if you find out that one of them, that the patient has unilateral cogwheeling, suggesting a stroke on one side in the midbrain, you might want to talk to physical therapy about educating that patient about, which side to use, which is their strong side and which is their weak side. So just, again, doing a deeper dive. And then also considering the time of day. So if those 7 o'clock falls are within an hour of eating, if dinner was at 6, you might want to do a post-meal hypotension blood pressure check. Next slide, please. So you also want to look at what may be causing the falls as what we call interceding factors. COVID, certainly one of them, and atypical manifestations of COVID. So falls actually is part of the differential diagnosis for COVID infection. It would represent an atypical presentation for COVID. Having a policy of checking post-fall with Bionex probably wouldn't be a bad idea. The issue is having staff, and the idea of not rotating people, but having the same people take care of the same residents is useful for maintaining that familiarity. And then we talked earlier about the high patient to staff ratio. I think that's controversial, quite honestly. The idea that, if you just, even if you had a 1-to-1 ratio, you're not going to prevent falls. So I think the impact of staff to patient ratio is somewhat overstated, but that's my bias. I'm not sure that the surveyors agree with that, but because everybody assumes, well, if you just have more staff, you're going to have fewer falls. I challenge that concept, because it depends on what the staff is doing. It's not so much what the staff is, how many staff you have. So anyways, next slide. Yeah, so this is the point I was making earlier. You look at that red box there in terms of hip fracture mortality. So the orange box represents about 10%. So 1 out of 10 falls can result in death in long-term care. So if you're below the 10%, then you're actually preventing falls with lowering the mortality, which is good. But look what happened during the COVID in 2021 here. So 2020, mid 2020 through 2021, you can see there's 3 times the mortality rate due to falls. This is not due to COVID, but due to the falls. Okay, next slide, please. Yeah, so I think what I'm going to do is I'm going to stop here, because we want to talk about the different risk factors. And this gets a little bit more in depth here, but I just wanted to share with you this Jerry Cult painting of a demented older woman. She's looking very kind of has that vacant look, but just a beautiful portraiture that was done in the 1800s. I'll just open up. Does anybody have any questions as we close up for today? And I hope everybody has a great 4th of July weekend coming up. But go ahead and unmute yourself if you have any questions or comments. Yeah, so we just want to point out the homework. So if you have your root cause analysis, if you haven't done that yet for falls, please submit that. We also would like you to identify what your primary intervention would be. So it's just simply stating, excuse me, that your intervention may be that we're going to do stand-up, sit-down physical activity every shift. So that would be the intervention, or that we're going to develop, everybody's going to be on 1,000 units of vitamin D facility-wide. So that would be the intervention. So we'd like you to specify that, and then start to put together your plan, do, study, act cycle as the basis of your intervention. So that would be another piece of homework. So 3 pieces of homework right there. And you can see where the link is, for the Dropbox. Any comments, Sarah? Did I cover that properly?
I believe so.
All righty.
Yeah.
Well,
and-
great. We're going to let you guys go and have, for those that are going walleye fishing, good luck. For everybody else that's catching sun, use your sunscreen. And I hope that you do see family and enjoy the weekend. Bye-bye. See you next week.